next topic, management of osteoporosis. I invite Dr. Usha Sriram to come to the stage. She has been a graduate from Madras Medical College, American Board Internal Medicine, American Board Endocrinology, and heading the Department of Endocrinology in Voluntary Health Service. And she has been
What did I do? Just go here, right? Either.
She's been one of the pioneers in the management of osteoporosis, and she taught me how to understand and diagnose and treat osteoporosis 25 years back when nobody was treating. Thank you so much.
Good morning, everyone, and that was a pleasant surprise because in 2023 I gave the Professor VTB oration online. So today, because I'm here in person, they honored me. Thank you so much. And everybody knows that both my husband and I are huge fans of Professor VTB and learned so much from him and continue to follow the things that he taught us in those days. And today's talk is on osteoporosis management. But before I begin, I just want to say what an amazing lecture that was given by Dr. Parandaman, and something as simple as cough, that he was able to explain it so beautifully, and then of course the entire talk on cranial nerve palsies. But unfortunately for osteoporosis, there is no symptom. See, cough is a symptom. You can work up and make the diagnosis. Neurologic palsies, it's a symptom. You can make diagnosis. This condition that I'm going to talk about, there are no symptoms. The only symptom is you break a bone. And kind of it's too late by then, and we'll have to work backwards in most cases. But what we really, as good physicians, we should be doing is to prevent those fractures. And that's number one. Number two is, even those who have had fractures, my good colleague Dr. Sriram Mahadevan will agree with me, even those people who have had fractures, we don't follow them up for osteoporosis. So we have these two golden opportunities. One is to take people, men and women, and prevent fractures. And those are mostly preventable. If somebody jumps from the 10th floor of a building, or we can't do anything, or they get hit by a vehicle, we can't do anything. But I'm talking about trivial falls. So one is very important as physicians that we prevent fractures. The second thing is the low-hanging fruit. Already those who have fractured, why not we make sure that they don't fracture again, because the next fracture is very common, and especially in the first 2 years after the first fracture. So we should be really making sure that people don't fracture again. And so I'll start with a clinical vignette and go through the different aspects of the overview, like what is osteoporosis and what is the scope of the problem, and why is it important that we even make the diagnosis of or assess the degree of bone loss, what can we do with that, and all the current tools that are available and how to manage them. That's really the management. And I've drawn most of my recommendations and things for my talk from this position statement that has been put out by the Indian Society for Bone and Mineral Research. It's again being relooked and some modifications may come, but just to say that I've taken it from this and also from the Asia Pacific Consortium on Osteoporosis framework for management of osteoporosis. So, like every important discussion, we should start with a clinical scenario. And I just want to say, this is a 63-year-old lady who had a fall in a vegetable market, and she's found to have a hip fracture. And she has had her menopause at age 48, which is the right age for menopause, both for, if you take Indian women, somewhere around 47, Western women, somewhere around 50. So she's she's in the right age. So it's not early menopause. And as a history of type 2 diabetes, for the past 10 years, she's on oral hypoglycemic agents, metformin and sitagliptin, and her A1C is 7.3. 7.3 can be a little bit better for sure, but it's not terrible. I work in VHS. The average A1C I see is 12, 13. So 7.3 is brilliant control for us. She's recovered well post-op and ready for discharge. But there are a lot of questions from her family. Number one question, why did our mother have a hip fracture at such a young age? 63 is young for a hip fracture. Is this because of osteoporosis? And she didn't have any symptoms. So the first thing that we all have to remember and also impress upon the public is osteoporosis has no symptoms. The only symptom is a break. You end up with a fracture. Usually if somebody has aches and pains or problem like that, it's osteomalacia. Osteomalacia is soft bone. Osteoporosis is thin bone. And osteomalacia is from vitamin D deficiency. So the pain is from when people have vitamin D deficiency, usually, or of course if they've had a fracture in the back and they'll have back pain. But not this Kai-Kal-Korachal type of thing is usually not a osteoporosis problem. Usually not. Then should we start her on any medications right away? Because she's just had a hip fracture, and what should we do? And how can we prevent another fracture? Very, very important question that the family is asking. So that's one important clinical scenario, and I'll show you the answers later. But I just want to say, as practitioners, we'll be facing a lot of these, like a gentleman who falls off a bus, is a tibial fracture, vertebral fracture. He's a smoker, but he's cut it down, but he's still a smoker. And he had a spine film because he had a back pain, and that shows on osteoporosis and a fracture. Then this 49-year-old lady who has rheumatoid arthritis has been on low-dose steroids, and she has a fracture after a trivial fall. And then a 75-year-old gentleman who tripped on a wire at a wedding, can happen to any of us, and he has no risk factors. He's not, his men are not postmenopausal, he's not on steroids, not a smoker, none of those kind of things, but he's 75. And this one is very important. A 58-year-old lady, she has done a DEXA as part of a master health checkup, and they find osteoporosis. So no symptoms, no risk factors, no nothing. Incidentally found osteoporosis. What do we do with someone like her? So these are the kind of things we normally face. And of course, nowadays, some people are coming to us even in their 30s and 40s and saying, my mom has it, or aunt has it, or grandmother has it. What can I do to prevent it? So why should we learn everything about osteoporosis? Just want to show you that by 2050, the people over the age of 60 in our country will be 19% of the population. And then by the end of the century, The elderly is expected to be 1/3 of our population. So you can see how osteoporosis is going to be, it's a problem of aging. It's a problem of postmenopausal state. So there's a lot we can do as public health, from a public health perspective. So the burden of osteoporosis is very high. As you can see, 1 out of 5 Indian adults, which translates to 20 crore population or higher, at the risk of getting an osteoporotic fracture. So that, and also it involves a high cost, not just in terms of rupees and paise cost, human cost. These are people who have high mortality within 1 year. They are people who have maybe another fracture. They may never return to their previous level of functionality. Almost 20% do not return to their previous level of functionality. And other issues happen when someone has a fracture. So it's not just a question of cost to the individual or to the healthcare system, but also in terms of health. So despite being so prevalent and so costly in every way, so underdiagnosed, under-recognized, underappreciated, and undertreated. Just don't know why. So really we need to take this thing on a war footing. And I just want to say, you take a person with diabetes. We spend so much time trying to bring their A1C under control, putting them on a statin to bring their lipids under control, try to get their blood pressure under control. And let's say, or now with all the obesity drugs, bringing their weight under control. Let's say we do all of this, but ignore the osteoporosis, and that person develops a hip fracture. That would be a crying shame, an absolute crying shame, that if we did not have this kind of a holistic approach, also because diabetes itself is a very high, big risk factor for diabetes, type 1 much higher, and type 2. So one is the fact that the population is aging, and second, this bone biology that keeps going on constantly. Bone is being eaten up, then bone is being put back, bone is being eaten up, and it's being put back. This goes on throughout our life quietly. We think bone is a dead tissue, just supporting structure, but it's actually alive, living, and constantly remodeling and doing wonderful things to our body, but we don't recognize that. So because this is also going on, and if there is an imbalance in this, and why can an imbalance happen? The imbalance happens for many reasons. It can be aging related, it can be disease comorbidities, it can be post-menopausal state. And I just want to show you that beginning from the menopause transition, the reduced estrogen leads to a decrease in critical bone mass. Do you see how rapidly and how much it comes down in that short duration? 5 to 10 years, we lose a significant amount of bone. So it's so important to make sure that women entering the menopause enter with good bone health, and they exit the menopause also with good bone health, and then subsequently we keep following them with that. So estrogen has multiple effects on these very important bone biology, on the osteocytes, osteoclasts, and osteoblasts. So if there is estrogen deficiency, this is going to happen. So the automatic question that comes up in people's mind is, so why not give estrogen and reverse everything? So it's not so simple. We know that some women will benefit from use of menopausal hormone therapy early on, especially if they have early menopause or premature ovarian insufficiency, or if they have symptoms. But otherwise, we are not using menopausal hormone therapy primarily for the purpose of prevention. So remember that patient who had 63-year-old who had the fracture. So there's some quick responses to the family. So why did our mother have a hip fracture at such a relatively young age? So risk is earlier in Indian persons, 10 years earlier, as we know, like most things. she's 15 years post-menopause and has type 2 diabetes. All are risk factors. In addition, diabetes predisposes people to falls. It can be vision problem, it can be proprioception problem, it can be a hypoglycemic thing, it can be any of those things that makes them fall easily, and therefore they're also at risk for falls. Is this because of osteoporosis and she did not have any symptoms? I've already told you, typically asymptomatic, and fractures happen because of what we call bone fragility. And I put this here because we now use the term bone strength, and bone strength is made up of both bone mass and bone quality. This quality is one abstract thing. There are a lot of things that contribute to bone quality, and that's why for the same bone density, some will fracture, some won't, and that depends on the bone quality they have. Should we start her on any medications right away? Obviously, optimizing her vitamin D, making sure her calcium is adequate. Use of specific agents. So this is something I want to leave here about osteoporosis. The role of the physician is in prevention, recognizing, screening, diagnosing maybe. But when it comes to management, you can seek the help of experts, and because it becomes a little bit more nuanced, because we want to risk stratify people and then choose the right medication, and we may not use the same medication. Now we have what's called as sequential treatment. We start with anabolic, then we chase it with the anti-resorptive. They may have been on anti-resorptive, we may have to choose something else. So it's a little bit more nuanced, but at least the first part, the recognizing, the diagnosing, the screening, the counseling, the optimizing of calcium, vitamin D, physical activity, all of that is the role of the physician, is what I'd like to say. And then how can we prevent another fracture? Obviously by following this patient and putting them on appropriate treatment. So how does the World Health Organization define osteoporosis? We use this classic T-score. So if the T-score should be normally up to -1. If it is up to -1, it's considered normal. -1 to -2.5 is called osteopenia, something like pre-diabetes. Then -2.5 and more is osteoporosis. And of course, severe is when either the T-score is very low, or if they have established fragility fractures. So this is how it is diagnosed. Now, next question I want to ask is, why is diagnosing osteoporosis important? So what if there is a fracture? You fix the fracture, you send them home, right? Not so simple. So first one is treatment of osteoporosis lowers risk of future fractures. And I just already said, fracture is not so simple. Edo kaal odanjadu, edo fix pannom kadiyadu. People lose their lives, people lose their independence, people lose their quality of life, people lose their livelihood, and so many things happen because they have a fracture. And then, is there a benefit if you treat these people, assess them? Why should we screen them and assess them? Number one, you rule out secondary causes. Aging, post-menopause is one thing, but you can get osteoporosis because somebody has rheumatoid arthritis, they're on steroids, they're on other medications, they have cancer. So many things can cause secondary osteoporosis. Second thing is, we need to document the extent of bone loss so we can choose which drug to use. So many are there now. And then also to monitor therapy. Choice of therapy will depend on severity, and also we must document incident vertebral fracture. So nobody will come and tell enakku mudu odinju poidhu. When their leg breaks or their arm breaks, you will know because it's broken. But if they have a fracture of the spine, very rarely they are going to come and say, I have fractured my spine, unless we look for it. The moment, so every patient you diagnose with osteoporosis or osteopenia, please get a simple lumbosacral spine. film, or if you have vertebral fracture assessment, VFA in the DEXA, you can do that. That is so important because it will completely change the risk stratification of the patient. Let's say you have a T-score of minus 1.9 and you see a fracture in the spine. Immediately that changes the risk stratification for me. So, and it is an absolute must that we do the spine film. And there are many, many tools that for motivating patients to adhere to treatment. See, imagine somebody who has no symptoms and you tell them you have to take these things for some months or years or do this and do that. They're not going to be, it's not like cough. They don't want to get rid of it. It's not like diplopia. They don't want to get rid of it. They don't have symptoms. So we have to impress upon them that fracture is not a benign condition. And primarily because big gap exists in evaluating and treating patients post-fracture. So really important for us to have a really good relationship with our orthopedics colleagues and work with them and make sure that all these people are followed up. And I'll give you a simple analogy. Just take somebody, they have chest pain. That's like a fall. Immediately we'll get ECG, we'll get cardiac enzymes, we'll rule out non-cardiac causes. Here we should do X-rays and other, ruling out other conditions. And then we would put them on antiplatelet, we would do some invasive interventions. But here we are supposed to do the fracture reduction stabilization. Following that, what will we do? Follow these patients, we'll put them on a statin, we'll put them on beta blockers, and now we put them on SGLT2. We keep following them up. Here we are supposed to be treating them for their osteoporosis. Do you see where we are dropping the ball? We're not doing any of this. Just imagine, it's exactly like that. So how do we determine who's very high risk and who's high risk and very high risk? High risk is T-score between -1 and -2.5 if they already have a fracture, and T-score between -1 and -2.5, and what's called a fracture risk assessment, 10-year probability of a major fracture more than 20%. Frax is like a poor person's DEXA. You can also use it with BMD also, but you can do a frax. If they're very high risk, of course, prior fractures, elderly, frail, increased risk of fall, very low T-scores, and they take medications like glucocorticoids. So let's see what tools are there for diagnosing and managing osteoporosis. Most important, history and physical. Complete history, what are the medical conditions they have, what medications they are taking, and as was mentioned very nicely, sometimes you have to ask people to bring their medicines with them. Appadan theriyum. They'll be on steroids for many, many years, or they'll be taking something they should not be taking. So very good history and physical. Then laboratory test, very simple. Always get a calcium and an albumin level to assess the calcium. Make sure you look at a CBC to see if they are anemic. And if they are, you have to connect the dots and see, could this be a myeloma? Could it be kidney problem? So also get a creatinine, very simple. Some very basic stuff. Get a vitamin D level. After this, if there is a calcium issue, then we can get a PTH level. If you suspect Cushing's or something, you can look for it. If you suspect a myeloma, you can get a protein electrophoresis. Other than that, very simple stuff is all that's needed. Of course, if they have diabetes, you want to assess their diabetes control. Then imaging. Imaging is X-ray, I already told you, but don't use an X-ray to diagnose or quantify osteoporosis, because it takes nearly 30% of the bone to be gone before you can diagnose osteoporosis. Also, when you start treatment, you can't use an X-ray to follow them up. So it's hard for us to assess, are they improving or not. So X-ray is to rule out fractures, not to make the diagnosis, except in very rare situation when we don't have anything, or if it is super obvious on the X-ray. And then I'll show you something about the DEXA and finally, also about FRACs. So these are the tools. History and physical, I already said. Personal history of fractures, family history, smoking, menopause history, breast cancer, post-cancer treatment, vitamin D status. A lot of people nowadays are vegan, they don't do this, they don't do that. So get a good history, and medical history for secondary causes. And then physical examination, look at their weight, calculate a BMI, look for kyphoscoliosis, clinical signs of secondary osteoporosis, and especially sarcopenia and malnutrition, very important. One of the reasons why osteoporosis is more common in men in our country is actually sarcopenia. So look for that. And then lots of medicines, as you can see, steroids and proton pump inhibitors and aromatase inhibitors, big laundry list of medicines that can cause. So you'll have to go through every medication the patient is taking. Then there is this radiographic techniques that are listed. All I want to tell you is X-ray to rule out fractures, and then the dual photon X-ray absorptiometry, which is the DEXA for the diagnosis. Bone markers, we really don't use it for diagnosis. We use it sometimes for following up the patients. And again, those are nuanced techniques and should really be left to the specialists. And we really don't do biopsies, and very rarely, these are research tools, very rarely we have to resort to biopsies and all that to make the diagnosis. So this X-ray business, I told you, I can't stress it enough, so important, because you will pick up fractures so often. And this FRACS is a tool. We have FRACS for India, though it's not Indian patients. They're Singapore Indians that has been developed. But now I think, Sriram, we now have Indian patients from Chandigarh. No. It has come in there? Okay. So we now have Indian patients. So you should use FRACS, and you put in the risk score, and you can also add BMD. It'll give you the risk for major fracture, and that's a very important tool also to assess. So the ISBMR, Indian Society, gives us recommendations. So we have lowered it from 65, the international guidelines, to 60 for Indian patients for women and 65 for men. And then, as you can see, for others earlier, if they have fragility fractures and things. So this is all you need to do. Get the spine, and we look at the total spine. Get the hip. We can just do one hip, left or right, and make sure that you just need to do these two. In special circumstances, CKD, hypo and hyperparathyroidism, conditions like that, you can do the forearm, but not in, we don't need the whole body DEXA at all. It's just spine and one hip. So the bone density, as you can see, as people get older, they are going to lose bone. The lower the bone density, greater the fracture risk as people get older, and also its prediction as for every SD decrease in BMD, fracture risk doubles. Okay, so we use T-scores except in premenopausal people and men and children, like I said, spine and left hip. So quickly, because the treatment is actually the simpler part. All this what I've spoken now is the most important part. So lifestyle modification, exercise, weight-bearing exercise, safe movements, avoid falling, balanced diet, sunshine, 20 minutes between 10 a.m. and 4 p.m., prevent obesity, avoid smoking and alcohol, limit alcohol consumption, and avoid all those medicines that I showed you on big list. You have to go through that. And then this calcium supplementation is under a scanner all the time. Just make sure people get enough in their diet, and maybe a 500 milligram once a day for postmenopausal people and older men. We don't need more than that. But vitamin D, major deficiency issue. 50% of patients with osteoporosis also have an osteomalacic component. So you have to make sure that their vitamin D is optimized, very important. Then comes the question, who needs pharmacologic therapy? Osteopenia or low bone mass, history of fragility, fracture, definitely, even if they have osteopenia. T-score of minus 2.5 or lower, definitely. And T-score, again, osteopenia, minus 1 and minus 2.5, but if their FRAC score, probability is more than 20%. These are people who need pharmacologic therapy. Just look over there. Look at the high-risk people and very high-risk people, and we treat them with pharmacologic therapy after optimizing their vitamin D. If they are very high risk or if their T-score is very low, we choose the anabolic agents, teriparatide, abaloparatide, which we don't have in India yet, and romosozumab that has come recently. We use these drugs, anabolic agents. Romosozumab is for 1 year, teriparatide is for 1.5 to 2 years. And then we finish that course and then close that or capture that with an anti-resorptive. But if they are only high risk, you can consider a bisphosphonate like zoledronic acid, or you can use denosumab. So treatment of osteoporosis, when you have come to this part, I think is a little bit more nuanced and should not be casually considered, and ideally we should take the help of the specialists. And as you can see here, if they are very high risk, use teriparatide, abaloparatide or romosozumab. Then you consolidate what you have gotten with the anti-resorptive, and then of course we stop it only if they have gone into a very low risk group. I also we always talk about drug holiday and all that. We don't give a holiday to people with diabetes or high blood pressure or heart disease. So even osteoporosis management, really don't think of as I'll use it for 2 or 3 years and stop it. We will have to use other agents that may be safer and keep monitoring the patient. So really no holiday that way. We have to keep on following them up. This is, all about these drugs. I just want to say again, they are all proven efficacious. We do not use calcitonin for osteoporosis treatment. We use menopausal hormone therapy for select women early in their postmenopausal years, but not afterwards. So we really are now down to just 3 drugs: bisphosphonates, denosumab, and teriparatide. Now we have romosozumab, 4 drugs only. So choosing that becomes based upon risk stratification and other complications of the patient. So really important for us just to keep that in mind. Very important that we don't have this gap of post-fracture assessment. That is a huge gap. Whenever people have new fracture, we are now having something called as FLS, or Fracture Liaison Service, not there in every state, in 2 or 3 states and in Europe, where special nurses follow the patients who have had fractures, proven to be beneficial. Hopefully that will come to more places in India. I'll stop here by just saying that most important thing about osteoporosis is preventing it by recognizing and screening everybody you think who's at risk, and following the guidelines on who should be screened, how should they be screened, and making sure everybody is following all these simple lifestyle measures to improve their bone health. Thank you so much.
That was a wonderful talk. I think in lack of time, we'll go on to the next topic. Thank you very much, Dr. Usha Sriram.